The next 2 hours is a little bit of discussion about the what I call the inclusion and exclusion criteria. I'll talk a bit what we think the protocol is going to be like, but we're always reserving. We may change it as we get closer and start to mess with it. So that's kind of this section, and then I'll do a quick section about bacterial and viral illnesses, because that's a bunch of the battle rhythm of primary care. And then at 11:30, we're going to go over to East Avenue, and then just walk through East Avenue. An exam room looks like an exam room looks like an exam room, but I've lined up a couple of people to take you through what it's like to, the patient experience is like, and from the moment that somebody calls us to the moment they get seen, to give you a feel for what it's like to be a patient there. So, when you get the opportunity to talk to somebody about coming over to Blackstone, they have a feel for what their experience might be like. So, in terms of the basic protocol, and I think that's kind of what I want to start with before we get to inclusion and exclusion criteria. The way we've thought it out, if you go on Seek and find somebody who you think could do well in the primary care environment using, actually I'll use the inclusion criteria that we're talking about. We're trying to start really simple, just people with these specific problems, and I'll talk about each one in a few minutes. Then what we're going to ask you to do is get on the phone, call over Blackstone. You'll probably get right to Dr. Sam, who will be carrying a hot phone. He's got no more than 5 minutes to come to the phone, but I think he will be picking up quite quickly. I'll probably carry it sometimes just in the beginning, just to get us started. We'll ask you to present the case briefly, and then he'll authorize transport, and then you'll come to the neighborhood health station, sign the patient out to the nurse, and then be gone. The basic principle is always that the guy in the field is the guy who gets to make the call. If there's anything that's ever uncomfortable that you think needs to be in the emergency department, do not pass code, do not collect $200, do not make a phone call, just scoop and run, because we don't want this to hold up the treatment of somebody with a significant or serious illness. So the EMT in the field is the person who makes the basic call. The clinician at Blackstone is there to make sure that we're not, without meaning to and over our heads, transporting somebody who doesn't belong in primary care. And we'll kind of ask you to stay with the criteria very strictly in the beginning, and then we'll see whether there are other people we want to open up for transport. I think that's the basic and most important.
Do they have to be a resident of Central Falls to be seen at your facility?
Yes. And, but you actually asked me a good and important question.
Thank you.
A critical one, which is, because of the way malpractice insurance works for community health centers, they actually have to have been to Blackstone before. So in the beginning, the numbers will be much smaller because fewer people will be enrolled, though plenty of people are enrolled now. So the first question is, on your side, is, do you go to Blackstone? And if the answer is no, then we go back to how we've always done it. So this is only for people who have been to Blackstone once, but our expectation is that over the next year, that number is going to climb to 70 to 80 to 90.
So how would they go to Blackstone if they've never been there? They have to walk in?
Yeah, well, they walk in, they call in, they come,
But they have
every
to
different
be-
ways of Sunday, but they have to have come once before and signed up as a patient. The community health centers, this is really obscure, are covered by something called the Federal Tort Claims Act. Community health centers are basically, their malpractice insurance comes from the federal government. And the only people they'll cover are people who have been through the registration process already. And that's why we're gonna have a bunch of people trying to get more people registered. And I suspect over time,
Are there people that are excluded from being accepted into that program?
nobody,
So just a matter of having been there before,
yeah,
But they still have to be residents.
and they have to be Central Falls.
they have to be Central Falls. Well, you know, if you walk into a walk-on scene, and there's somebody who lives in Pawtucket, but is in Central Falls, and is a Blackstone patient, I don't think we really care that much.
Well, how would they be if they don't live in Central
Well,
Falls?
because
They're
they have
residents.
they have
They
meals
can- back
and
there.
stuff.
Yeah, they can be,
They can be.
remember, Blackstone has two
It's a
big sites
community.
in Pawtucket, so there's plenty of people who go to the Pawtucket sites from Central Falls, relatively fewer people who come to Central Falls from Pawtucket, but I'm guessing that number will grow, that more people will come to the neighborhood health station, and people see the, spanking clean, beautiful new building.
Mhm.
But the basic question is, I mean, are you a Blackstone patient? And then, the other thing I want to talk about for a minute, this is kind of on the agenda, before I go through this other stuff, is how to present a patient. Because one of the things that I had to learn as an intern and a resident, and how doctor types think about the world, is we think a lot about patient presentation. The way I think about a patient and the way I hear about a patient helps me be able to move quickly through the, yes or no, and so how you guys present turns out to be really, really, really important. It's a real skill that we spend lots of time teaching medical students and residents. And the thing I will tell you at the outset is that when I present a patient, I try to present the patient in a certain way backward. I know what I think, but I want to present the patient so that the person I'm presenting the patient to ends up thinking the same thing. But what I start at is I start at basics. I start at, age, gender, some descriptor. Often it's helpful to me in our environment to know whether the person is English speaking or Spanish speaking. Presenting complaint, and what I think and what I see. So, 37-year-old Spanish speaking female presenting with abdominal pain of 3 days duration, and then vital signs, no fever, blood pressure 120/70, pulse 88. Just having told me that much, I actually learned a whole bunch about what I'm going to think about and what I'm going to do. So the discipline is to stay with that formula and do it every single time, because you will prevent 100 questions if you deliver that information and deliver it in that order and deliver it quickly. And then, maybe a little bit of, abdominal, any other contributing factor, no nausea, vomiting, or nausea, vomiting, I'm not gonna, you don't need to do like what we call a whole review of systems, but if there's something that's significant, I want to know it. In our environment, working together, what I really want to know is that there isn't anything significant. Because, the moment I hear rectal bleeding, I'm saying, go to the ED. The moment I'm hearing a child less than a month old, I'm saying, go to the ED. The moment I'm hearing, unconsciousness or unarousability, I'm saying, go to the ED. And in your environment, the opportunity is, if you've gotten that point and got somebody who I'm going to say go to the ED for, then you can save everybody a whole lot of work and not call me at all. Just go to the ED. The opportunity is you guys are in control of that, and so the people who decide whether we're going to the ED or not is you. So, anybody want to try one just for the heck of it? Just make one up. Thought we might go around the room and everybody do one just for fun. Because this takes, believe it or not, this takes practice. And the more you do it and the more you hear it, the more you're used to it. Anybody willing to be first? Looks like you are.
26-year-old male, English speaking, with a headache for 3 days.
Vital signs.
I'll throw this curveball at you.
Yeah, please.
210 over 110.
Yeah.
Pulse of 118.
Right, cool. Afebrile.
Hmm?
Afebrile or febrile?
We'll go AFib.
Okay, cool. So I'm gonna ask you one question, and then we're done.
Lamb scar?
Excuse me? No, I'm not gonna ask you one right
Lamb
now.
scar 0.
Yeah. But that's kind of the battle with it. Because you presented that so well, you know, I can with one question say, you know, yes, transport or go to the ED. You know, a lot of this depends on your, you know, sort of package for presentation. Who wants to be next? To my right?
Sure.
Yeah.
Rash on his hands, feet, and mouth.
After 2 days of 102 fever. Yeah, I got a 27-year-old presenting with rash on hands, feet, and mouth.
27-year-old male or female?
27-year-old English-speaking male,
Perfect.
speaking
Still speaking.
still speaking English, hasn't changed his language. Experiencing rash on hands, feet, and mouth for 2 days after experiencing fever for 2 days of 102. Patient complains of no nausea. Patient's vital signs present within normal parameters for age. Patient is stable.
Perfect. Next.
You wanna see him or don't you?
I'm not even thinking that much. I'm just
Oh, because
practicing.
I'm curious.
All right, let's do it again.
So what's wrong with him?
27-year-old.
27-year-old English-speaking male complaining of rash on hands, feet, and face region. Patient complains of a fever 2 days ago, maintaining around 102. Fever has since dissipated. Patient's vital signs present within normal parameters for age bracket.
Send him over.
Patient stable.
Sounds good. Next.
58-year-old Spanish-speaking female. Just says she doesn't feel right today.
Coming up with it off the top of
Vital
his
signs.
head. Right off the
Started
cranium.
this morning when she woke up, vital signs were all stable.
I'm gonna want more than stable. I want the numbers. I'm gonna be a pain in the ass.
Alright, SpO2, 99%.
Perfect.
138 over 86. Pulse is about 98. Breathing normal, not labored.
Sandro, sounds good. You know, I would agree. What would have made me react a whole lot differently? You know, if I heard a pulse of
Cardiac history.
126, if I heard a cardiac history, if I heard an O2 sat of, you know, sort of less than 95 or so, then I'm going to say I'm going to call it different. But you provided the data that I needed organized in a way that I could process it and process it fast, so we didn't have to spend much time on the phone.
So everything has to be authorized before they can transport to your facility
That's correct.
with a phone call?
That's correct. That's the way we're setting it up. So that we work together as a team and we don't blunder into a country that we don't want to be in.
Who's gonna be answering that phone?
You just said there's a register.
Just pay
It will- As we're thinking it out now, who's going to be answering that phone is going to be the Express Care doctor on the other side. And like I said, it's a hot phone, and if they don't pick up right away, you go to the emergency department.
There's a chance it could be a doc or a PA or a practitioner, right?
I'm sorry?
Chance on the other end, it could be either a doctor or a PA or a practitioner, right?
Yeah, as far as I'm concerned, it's got to be one of those.
Okay.
There might be a nurse, you know, somebody's like right in the middle of something, but nobody less trained than a good nurse.
So the janitor is not gonna pick up the phone.
The idea is that it's a hot phone, it'll be a cell phone they carry on the belt. We tried the janitor, wasn't that good at it. He didn't know how to do these presentations.
I have a quick question as far as like a consult. So like if you have a patient, we've had them before with like a UTI,
Yeah.
who's been taking them, an elderly patient, who's been taking them for a day, after they went to the ER, they haven't given the meds enough time to kind of kick in. Would that be a phone call with their Blackstone palliation? You could talk to them and say, wait for the rest of your UTI medication to take hold before you just be brought back into the facility?
You know, it's a great question, and we're not there yet. My guess is, as we work together, we might develop that, but my aim on the front end is to keep this simple, to have it very tightly protocol. So there's, you know,
No
not,
wiggle
So do
you know,
you,
we're trying to keep the wiggle room down in the beginning till we're used to working together. And my guess is as we get used to working together, as you guys get used to the voices on the other end and they get used to you, we're gonna be able to do things together quite well and with quite a great deal of.
these protocols that you're developing, are they in conjunction with the state protocols that we're bound to work under?
They are.
So
We've
there's no
actually-
conflictions,
We've got the state blessing to do this. We applied to the
okay,
state.
but
for-
nothing conflicts.
Nothing should conflict. I'm hoping that Jason Rhodes will be here in a day or two, and he'll be able to comment on that with more precision. He's been part of this process from the beginning. Who is next?
27-year-old female, Spanish-speaking only, complaining of vomiting and diarrhea at times 24 hours, admits drinking alcohol for the past 48. Vital signs are stable at 128/78, heart rate 142, respirations 20, SpO2 98, on room air, temp of 101.7.
I think I'm gonna say, go to the ER if somebody's intoxicated, because I'm not sure that's what we're ready to do.
Wow.
So that's 70% of our calls.
Yeah, I was just gonna say that, you just gave away. Alrighty,
Well,
that takes care of that.
yeah, we'll see. I mean, you know, but, you know, I might ask you questions, you know, showing obvious signs of intoxication, or has she been drinking a little bit?
Well,
That's
patient
hard to-
admits to drinking for 48 hours on
And if
Saturday,
they
Sunday,
admit to
then you
drinking
want to
straight
report.
48 hours, then they've been drinking for, you know, like 96 hours. Anyway, usually the patient.
About how much drugs and alcohol they have to take?
Never.
Okay. Just for-
But, you know, I mean, this is where a positive response has some meaning, but a negative response doesn't get you off the hook. And that's the way we all learn to think about this stuff.
4-year-old male with a fever, unknown amount of time, unable to interpret because we don't have a full language on scene.
Okay, that's, how high is the fever?
Unable to obtain. Also, we know is we have a fever.
No other vital signs?
Nope.
Blackstone Valley patient, just a fever, plain or lethargic?
Plank.
Bring them over.
Okay.
The plain question is gonna turn out to be important. You know, when I look at a kid, my first eyeball tells me almost as much as I need to know.
What, I'm sorry, what would you do in the case of, you brought that patient in and it turns out it's more serious than what you can handle? What do you do at that point?
I'll call you guys and say,
You're gonna call it back to
Go to
transport that?
yeah.
So you don't have a private ambulance factored into this?
Well, we
Or
do.
like routine
We do have,
round trip
we
transfers?
do have some private ambulance stuff that we use for what I call routine. But if
But that
it's
would
a
be
4-year-old
emergency.
with a fever,
Yeah,
and, you know, if they turn out to have a meningococcal rash, you know, because what am I gonna send a 4-year-old to the hospital for? You know, if I think they've got meningitis.
Right.
And to me, that's you guys, that's not waiting an hour for,
right.
you know, somebody to just show up. You know,
So that's why we need that other rescue. You're gonna have to buy us another rescue. I just made up my mind.
Do you have any
I do.
Excuse me,
We need another rescue.
can you explain what the private ambulance aspect is gonna be?
we haven't really thought about it, but we have one that, you know, we try not to overload local services. So we don't use them all the time, but sometimes if we call and somebody's backed up,
How about
Blackstone will
Uber?
call
Have you
private
thought about that?
ambulance.
You could use Uber for some,
Well, we're thinking,
or some type of,
Lift.
we've actually been doing we have a conversation going with other
yeah.
for certain sorts of things when they call us. But we, you know, obviously we want to keep that pretty close to the vest because we don't want everybody using Uber just because it's Tuesday.
Right.
You know, I mean, if people want to use Uber, they're pay for it themselves. You know, most of the time. So we want to keep it for, you know, people who just have who
I
really.
think if you can get the app and, you know, just have Uber bill you, it would work.
Well, we're,
Most of the problem with transportation and treatment is that they have no money. That's it. It's the underlying problem. It's more than your medical.
They have no money or they don't pay.
all right, next.
That's a big difference.
Thank you, Chief.
On that point again?
I think that was a pass. Anyway,
You're not feeling well.
It's your muscles.
You wanna go back on that?
All right, say, 48-year-old male, English speaking, stating he has a cocaine addiction and is looking for rehab. Vitals are all stable, says he last used cocaine 12 hours ago.
I was gonna bring him over. Next, sorry? Because we actually have behavioral health people who can get them up into rehab. We have a full-time recovery coach who works with us on that.
Doctor,
Then I have-
why bring someone addicted to cocaine and not a regular drunk?
Because the regular person with alcohol use disorder, actually, you know, there's a risk of, there's a 10% mortality associated with alcohol detox. And we don't really have the capacity to give them the treatment they need to prevent that detox and mortality.
Well, heroin,
Sorry.
So, if you bring somebody there for cocaine, don't they ultimately have to be cleared, medically cleared by an ER before they can go to a facility? Or your facility will be able to medically clear him and go right to Butler, say?
Actually, if somebody's not active, you know, I mean, I don't know that for sure, but I've never heard that people need to be medically cleared. They need to be medically cleared by Butler, for Butler, but most people who get moved to treatment
Go in, Joe.
actually don't do that. They do outpatient treatment that doesn't require clearance. But it's Butler, you may have noticed that Butler can be a little twitchy about this stuff. So this is kind of a Butler thing, not an everybody thing. In fact, most people who need treatment for substance use disorder get treatment as an outpatient, not as an inpatient. Inpatient treatment is shrinking by the day, because it turns out not to be as effective by itself as people used to think. We used to think that everybody needed inpatient, and those numbers are going, you know, are shrinking pretty rapidly as people find better ways of doing outpatient treatment, including various kinds of medicine-assisted therapy, which is now the mainstay of, you know, of what we get people started. So, next victim.
12-year-old English-speaking female, suicidal ideations.
Suicidal ideation will go to the emergency department and
That was one of my questions. I see anxiety, but I didn't see a lot of mental health disorders. And we get a lot of calls like that, say schizophrenia, bipolar.
and we may go there eventually,
Mhm.
but like I'm saying, we're starting simple.
Okay.
We're starting with the, you know, stone cold obvious, you know, like the person with the sore throat. You know, as we get used to each other,
Mm-hmm.
and as the neighborhood health station gets its chops, you know, gets up and running and gets used to working this different battle rhythm,
Mm-hmm.
I think we may change it over time. But we took real care to make it super obvious,
Yeah.
so that we start with people who we basically can't go wrong on.
Mm-hmm.
Famous last words, because there's never can't go wrong in healthcare.
Mm-hmm.
But we start with those guys, and then as we develop more skill and more teamwork, you know, we may do it a somewhat different way.
Gotcha.
You know, and the rest of the world's gonna change as well. You know, there's that behavioral health thing that's now in East Providence, that's supposed to be able to take care of people with behavioral health crises. I have no idea how that's gonna work, whether it's gonna work, how it's gonna play in this, you know, but there will be other sorts of services that come and go in our lifetime that will impact what we do together. The importance is to get used to working together and thinking of ourselves as doing this together, instead of thinking of ourselves as totally unrelated entities, because we're not.
I got another one. 35-year-old, English-speaking female, upper abdominal pain, diaphoretic, vital signs are 140/90, heart rate's 110. SpO2 is 95.
and, 95, and pulse?
110.
I'm probably gonna say ED.
This isn't the time to find out if you did the right thing on runs.
Next,
26-year-old male, English speaking, severe tooth pain, claiming 10 out of 10 pain with a small fever of 100.8.
vital signs,
Vital signs 120 over 80, perfect, pulse of 82.
bring them over. That's exactly what we're good for.
Back on rescue, Sean.
Wisdom tooth people, we get them all the time.
Yeah, but we got dentists.
Yeah.
You know, I mean, the ED doesn't have a dentist,
No, they go there for nothing.
right? Well, they go there for opiates.
Yeah.
And antibiotics, but, you know, then they gotta go, then go to the dentist. So why waste the extra trip? Let's just bring them over and get them taken care of. Anyway, next.
I think he has a question.
I think you have MRI capability there.
No. At least not in the immediate future, just plain films. In my dreams, maybe. Anyway. All right,
Look at him, Mike, look at me.
curveball.
Oh, I don't think I have a curveball. All right, 2-month-old patient, restrained in a car seat, minor MVA, no other injuries in the car. Mom wants the child check for her peace of mind.
2-month-old,
Just car seat, restrained, facing the right way, installed properly.
describe the mechanism of injury.
Head on, minor though.
Minor, what
No
was?
airbag deployment.
No
Sorry,
airbag
the
deployment.
windshield.
So eventually, I'm gonna eventually say, bring them over, but on the front end, we're not gonna meet our initial criteria. We're not gonna do this for kids less than 1. We're just not, and I'm gonna sort of encourage everybody to be particularly cautious about kids less than a month of age. I'm gonna talk a little bit about the month of age
Less than a
thing.
year.
Excuse me?
Less than a year?
Well, less than a year, we're probably gonna say no to anybody less than a year, but I just want to take everybody through, you know, sort of an almost unrelated way, the risks of taking care of kids less than a month of age, because there are some real dangers that not everybody knows about. Next.
50-year-old male patient, chief complaint of difficulty breathing. He was 2 days. Vital signs are stable. 110 over 70. Pulse ox is 98. His rate is 110.
Bring them up. Sounds great. You were the lead off,
I can go again.
right?
I'll give you something, I'll make you blush.
27-year-old male,
I
English male.
I don't blush. I've been to that one.
27-year-old English male, says he
Hang
woke
on, I didn't hear the beginning.
27-year-old male, English male, complaining, said he woke up, painful urination, some sores to his genital area, says he wants to kill himself. Vitals are 120 over 95, pulse rate like 130.
Says he wants to kill himself.
Can't go.
Can't go. Without this says he wants to kill himself, bring him over. That's what we do every day. Every day.
I looked ready to
Day in
go
and day out.
until I wanted to kill myself.
Well, you just described yourself, you just have the age wrong.
It's not funny. Now you know where you can go, bro.
We haven't thought about that. That's a good question. But we need to do some things.
What's that? Really good
I don't know the
question.
answer to
On
this.
his genitals.
Asking in regards to.
He's got some sores on his genitals.
So like,
This is all gonna be. You know, we are not
You
the
don't
AD.
get to kill
You know,
yourself.
the
Now he
AD
wants
is
to kill
really
himself.
important for a bunch of stuff. We're really important for a bunch of other stuff. The challenge is just making it.
I got you.
In the back.
That's awesome.
35-year-old male resident of one of our local halfway houses, combative. Staff called us to transport the male because he was being combative with his roommate, won't let us take any vital signs.
Combative goes to the ED.
What about aggression? Any signs of aggression?
Aggression to the ED. You know, we don't have,
Passive aggressive people, you know.
I've never met any of those.
No suicide.
John, you wanna draw me one?
Very 50-year-old female diabetic patient, alert and oriented, diaphoretic, complaining of nausea, vomiting, headache, productive call for 48 hours, 130 over 80, 88, 18 for respirations, 101.8 for a temp, and a glucose of 300.
300, I think you could do. 500, probably not. But that was a good presentation, thank you. Thanks.
27-year-old English-speaking female, grand mal seizure for 20 minutes. Blood pressure is 120/80. Heart rate is 120. SpO2 is 95.
I would have stopped you after the grand mal seizure, but I want, hearing you speak was what I was looking for. But after the grand mal seizure, that's the ED.
Call for a well-being check, 97-year-old female, unable to speak, so we're not sure what her language is. She's in a fetal position, she's grasping her abdominal area. Her vitals were 100, over 70, respiration is 22. The pulse was 88, her temperature was 102.
That's a great case. That's always the ED unless she's got a code sense. It's always the ED. Anybody over 65 with abdominal pain, actually often, almost everybody needs imaging, CAT scan or MRI. The standard of care has really changed about that. So, elder people with abdominal pain, we need stuff that Blackstone doesn't have. And actually, something that I'm trying to get my Blackstone office that when you see abdominal pain in an elderly person, they're going to need imaging. Because our usual, in elder people, our usual kind of guideposts like vital signs actually aren't that accurate. So there are lots of people who will rush to this and walk around ahead. How they do it, I don't know. In a younger person, they have a fever of 104. It'd be shocking, but older people, all bets are off just like little babies. Want to do one?
I gave you 3 already.
That's what I thought. All right. You guys did great. But that's the kind of presentation that will help us work together efficiently. So, the inclusion criteria: sore throat, cough, allergies, earache, back pain, neck pain, rash, fever, headache, and anxiety. Not, sort of in the middle of a schizophrenic Drake, sort of not somebody who's shocky, but all these other folks who have a headache, have some nausea, vomiting, have an earache, have a headache. That's where we're looking to be able to take care of here in town, here in the city.
As of right now, anything that's like in custody, which is like just, the patient's trying to get out of the cell, would just go to the ED.
I think that's a question that just came up.
Yeah, no, I was just
We actually haven't thought of it yet.
Okay.
So at the moment, I think in custody probably needs to the ED, but, I think that's a great opportunity for us to work together, because as you said, I spent a year being the medical director of PACI, so I kind of know the other side of it.
Cellitis.
I'm sorry?
Cellitis.
Yeah. And, that may be, if we can get them registered, then that may be the trick, registered at Blackstone. Then we may be the ideal place for that, because, we're right there on the corner. All right, so, go ahead.
Are you going to be sending case managers or any of the people from your office to the calls? Because I had that recently. Someone from your office went to one of our emergency runs.
Right.
So I don't know what's the situation there.
I actually spent a lot of time learning about that particular situation. That was 2 different calls. I mean, what happened specifically was the doctor called DCYF. DCYF said, we don't know when we can get there. And so the doctor then called one of our community health workers to go out. DCYF, without telling the doctor, then called for the police department, and the police department called you guys. And then DCYF showed up 2 hours after you guys were there, and ended up taking the kid to the ED. And that's actually where some of my comments about kids less than a month old are going to come from. But the actual answer to your question is no, that we're not routinely sending people out. But that was a case in which the doctor had a very specific reason for being concerned, had an obligation to call DCYF, she did that, and it turned out that DCYF followed you, Blackstone did. So, as we drilled down on it, which we did, we spent a fair amount of time on that case.
Patient care is not gonna be transferred to us if they're on scene, or
They're not gonna be on scene. There's no reason for them to be on scene. You know, that's not what we in general do. It just, you know, when the doctor couldn't get DCYF to say they would go out, and DCYF didn't bother to tell us that they were calling the police department for a well child check, which is what they did, the doctor did the next best thing to protect the life of the child, which was to send somebody out to eyeball her, and make sure that she could. The idea was to have that person kind of drag the person in to see the doctor, because that kid hadn't shown up, and there were reasons for being concerned that that kid might actually be in some very significant trouble. Now, it turned out that that kid it was a feeding problem, and we got by on that one. But that was one that really, you know, kind of raised my eyebrows, because that was an accident that was waiting to happen, which we ducked because we were lucky, not because we had it figured out exactly right. And that was everybody. You know, that's where I think, you know, to me, that's sort of like a prime example of how we all could learn to work together. And one of the things that I'm going to try to do is sometime in the course of this week, bring the community health workers from Blackstone over to wherever we're going to be tomorrow. Because I'm told we're going to get a better place, you know, more spacious place.
You don't like the mold?
But, so that everybody gets to meet each other. So, you know, you can put names and faces together and understand who does what and what they do, so we get a little. So, absolute bypass criteria, crushing chest pain in patient over 40. My guess is we're probably gonna end up with crushing chest pain in anybody. You know, let's be real. Oxygen saturation less than 92%, profuse bleeding, vomiting blood, active rectal bleeding, unilateral loss of muscle strength. I'm going to talk about strokes later in the week, but anything that looks stroke-like, we're going to say, you know, stupid run, because there's actually now some evidence that Rhode Island is doing better than most places, because we're getting people with strokes to the ED quickly and getting aggressive intervention. Threats of violence to self or others, absolute bypass criteria. Bleeding in pregnancy, my guess is we're going to start with pregnancy itself mostly as a bypass criteria, but we're going to tune that up as time goes by before we get this thing started. And just in terms of time course, you know, my guess is we're actually going to start mobile integrated care together probably about the beginning of February, maybe the beginning of March, because Blackstone doesn't move into the new neighborhood health station until about January 1st. And I want to give Blackstone a time for a shakeout cruise so that all the systems are go and working. We've tested them and they're in good shape before we start to do one more complicated thing. So bleeding in pregnancy, active labor, decreased fetal movement, unconsciousness or delirium, hypertension, certainly blood pressure less than 90/50. But, you know, sometimes shock is a clinical evaluation, not a number, and, you know, anybody who's in shock by your eyeballs, stupid run. Respiratory rate less than 8, respiratory rate greater than 14, angulated or amputated limbs, sexual assault, wheezing or absent air movement, fever in anybody on chemotherapy or is known to be neutropenic, anybody after Narcan, any seizures, so we're actually getting at some of the questions you guys asked. Any deep wounds, I mean, you know, I love sewing lacs, but they gotta be little lacs. You know, I'm not gonna do the, you know, sort of 20 centimeter messy lac, you know, but we're all good at knocking together a, you know, 3 to 4 centimeter lac or smaller. You know, anything complicated on the face, we'll probably say go to the ED. But the straightforward ones on the body, you know, I bet bread and butter.
Quick question before you move on about the Narcan. What if we go somewhere to like a scene of an overdose where somebody was given Narcan at the house or by like a bystander?
Anybody who's had Narcan, go see ED.
All right, this is but given by Narcan, given
Oh,
by
okay,
rescue.
given by rescue, it actually is given by anybody, you're right, good question. Let's see, deep wounds, third-degree burns, or partial thickness burns, more than 3% of body surface. Severe allergic reactions associated with difficulty breathing or any poison. Eye injury, crushing hand injury associated with angulation or severed digits. And then I just wanted to talk a little bit about what to be scared about for infants less than a month of age, because they scare me. There are two things that's worth knowing about, what are called late and early and late onset group B sepsis, which can lead to shock and death in 24 hours. It is a very, very scary infectious disease. And the newborns may have no fever. Late onset, usually they do have fever, but sometimes these kids just show up a little irritable, a little lethargic, and it takes somebody really good at assessing them to know what's going on. And then there's what's called the late presentation of congenital heart disease, kids who are born with malformed hearts. You may not see until 2 to 4 weeks after they're born, and it sometimes shows up only as sweating or cyanosis with feeding. If they're not feeding, then you have no real way to assess whether they are in trouble or not. So what I'm going to say for this, and what I'm going to suggest for everybody, is if you get called for a 1-month-old, take them to Hasbro, because there may be a disaster that you don't see when you look at the kid. The kid may look okay, but infants are really, really, really hard to assess. And little ones, they can crap out and disappear in a couple of hours. So you never want to be in that situation. But I heard about your case. I thought it might be worth reviewing some of this stuff, because it's, you know, I mean, they told me this stuff in medical school, but they never taught it to me when I was an EMT, so I thought it was required to guess on that. So let's take a 5-minute break. I'm going to switch slides, and then we'll do one more presentation till 11:30. Then we're going over to 11:45. And we're going over to 39 East and just get a walkthrough of how the operation works, not what an exam room looks like. All exam rooms look the same, but I wanted you to get a feel for the people in the flow and what it's like to be a patient. So you have an idea of what it's like when you see and work